So this is where I work now, and the Service User Research Enterprise at the Institute of Psychiatry, SURE for short, and set up in 2001. And I was its first, I came into the job as called project coordinator. I soon dropped the project and called myself coordinator. It started off very small. There was just me and an administrator. And actually the job description was to get local service users involved in research. And I did it, and it was nice. But it was kind of, the Department of Health were beginning to think that they should have user involvement in research. And they had set up consumers in NHS research, which became involved. And that unit was supposed to help get service users involved in research. And this didn't last because lots of other people did it. But having a service user unit at a place like the Institute of Psychiatry became a license to print money, basically. So we got 3 huge grants in the space of 9 months, and we grew. The number of staff we have depends on our grant income. Nearly all of us are users or ex-users of mental health services. And that means, to me, that we have insider knowledge. And it's from this insider knowledge that we create user-produced knowledge. We're at the Institute of Psychiatry, as I say. The Institute of Psychiatry is the biggest psychiatric research institute in Europe. We're meant to be collaborative, and we now have a balanced management structure. I am co-director, and I'm a service user researcher, and my other co-director is a professor of psychology, so it's supposed to be balanced between clinical academics and service user researchers. This is the first new method that we developed, patient-centered systematic reviews. The method that we use is, now this is where I'm saying you won't think I'm very radical. We do what systematic reviews always do, in that we collect together papers on the same subject and do a meta-analysis. But normally when that is done in psychiatry, only papers published in very high-profile journals are included. We included what is called the grey literature. That is literature that hasn't reached the high-profile journals. And that was reports and we include reports and papers authored by user organizations or individual users. That's all quantitative. But we also supplement the quantitative data with first-hand testimonies, which you'll see an example I'm going to give you. We even have a novel method of dissemination, which I can say in this context. We make videos, if we can, of people giving their first-hand testimonies. The crucial thing is that the researchers doing this work have experienced the treatment or service in question. And that's why I think it is user-produced knowledge, because we know what it is like to have received this treatment or this service. And we put that knowledge into our research. Being a user researcher isn't just being somebody who has used mental health services and is a researcher. You have to bring the two together. You have to use your experience of mental health services to inflect the research that you do. So this is my example. This is the first piece of work that we did. Consumers' views of ECT. The 2 main researchers had experienced ECT themselves. Now, I said SURE was collaborative. The 2 main researchers did most of the work, but we also had a psychologist with expertise in memory, and you'll see why in a minute, and a psychiatrist with expertise in legal aspects of psychiatry. We searched the literature, and we found 26 papers on patient perspectives on ECT authored by clinical academics. We just did this the way professionals do it. We also, from our own knowledge and talking to people, we found 9 reports authored by service users on what did people think about the experience of ECT. That 26 and 9, 35, make up what we call the quantitative data set. Then we found some testimony data, and we actually used the internet. We found testimony on email threads and in a video archive. Have you heard of the testimony archive? Yeah. It's a video archive of 4-hour interviews with 50 people talking about their experience in the old asylums. It's in public view in the British Library. And we searched through the transcripts and found occasions in which people talked about their experience of receiving ECT, and we put that into our qualitative data set. We had a reference group of people who had received ECT plus a couple of qualitative researchers, and the themes were perceived benefit, do you think it helped you? Permanent memory loss, because the reference group said this is a really important issue, the ECT is causing us to lose memory. People talk about things like, I have holes in my memory, I have gaps in my memory. There was a big issue about information, consent, and perceived coercion. Perceived coercion, consent and perceived coercion, meaning you need to sign a consent form to have ECT unless they're going to give it to you under coercion. But people were saying, I signed the consent form, but I didn't do it freely. There was pressure on me to do it. And we looked at emotional response. So when we did the meta-analysis, we found we couldn't do it. Because the idea of a meta-analysis is that you take the results of all the different papers, say on perceived benefit, and you pool them to get an average. And the average is supposed to be a better estimate of the perceived benefit for the population as a whole than any single paper. But when we did it, there was no overlap. The service user papers did not overlap at all with the clinical academic papers. The criticism that we had to face was, well, this is just bias in how the user-led work chose its samples. They sent them out to their membership. Not all their membership had ECT, and only the ones who criticised it sent back the questionnaire, so what do you expect? We had been on wards, we had received ECT, and we thought, well, what would it be like if the doctor who had treated you came along and said, can you answer a few questions for me? Do you think this treatment helped you? Are you getting better? Well, how would you react to that? You probably just want them to go away. You wouldn't want to say, no, I don't think it helped me, because you're in such a powerless position. So we were able to use our experience of being in that position ourselves to critique the methodology in the clinical papers. The qualitative analysis, as I say, first-hand accounts of receiving ECT from email threads and the video archive. The project had a reference group which suggested initial categories, which are the ones I showed you before. We read the material very carefully, and we used framework analysis, which is basically a simple qualitative method where you work with grids. Now, this is a very funny thing. Although there was no overlap at all on the question of perceived benefit between user reports and clinical academic reports, there was agreement on long-term memory loss, information, and consent. It was agreed in the results of the papers that the main side effect of ECT is long-term memory loss, but there was a total disconnect in the professional papers between the results and the discussion. So in some papers, the results would be, there's long-term memory loss, and they would give the proportion. And in the discussion, they somehow managed to spin it to say, no, memory loss is not a problem. And I found that very odd. And about half of the people who received the treatment said they did not have sufficient information beforehand. Well, the clinical papers took that on board and said, we've got to be better at giving information. And as I said, about 1/3 said they did not freely sign the consent form. For example, there was one woman who said, well, they made me sign it late at night after I'd taken all my medication and I was practically asleep. And that's supposed to be, consenting freely to a procedure that is contentious. The dispute. We had they didn't want the qualitative analysis, but the BMJ published the meta-analysis. At which point, the Royal College of Psychiatrists issued a press release disputing what we had said about their patient information leaflet. I mean, can you imagine issuing a press release about a 2,000-word paper in the BMJ? And it was all very odd, because they had a paragraph in their information sheet with the last sentence of which was, as far as we know, this ECT has no permanent effects on your memory or intelligence. And when they reprinted the paragraph to show that we've misrepresented them, they left off that sentence. But they did remove it from their website 6 months later. And I think this story shows that when you begin to develop user-produced knowledge, and it was very much the two people who'd had ECT that were spearheading all this, we were the ones that were getting it in the neck, and we're a threat. So, doing a meta-analysis, doing systematic reviews may not seem a very radical thing to do, but you can inflect it in such a way that it does come across, at least to mainstream psychiatry, as a real threat to their theories and their practices. Anyway, we were very pleased because the National Institute of Clinical Excellence was conducting its own review of ECT as we were doing ours. It was received very favourably, which we were chuffed about. And the use of ECT now requires much tighter safeguards, especially in relation to information and consent. And really, there's not a lot of point in having a conversation between the BMJ and the Royal College of Psychiatrists at the level of, who said what to whom, unless you can have this kind of impact. In the email threads, there were people who said it had saved their lives. Right. The main thing, people do say it saves their lives, but there seems to be something going on that's like a trade-off. That I'm prepared to put up with memory loss as long as I get rid of this suicidal depression. And of course, some people don't have the side effect. It's just you can't predict in advance if you're going to have it and who's going to have it. I'm not denying. In the testimony archives, I'd say 20% of people said it had a beneficial effect. And in the email lists, probably the same. And some people there was one woman in the testimony archive who just said it was normal on the ward. Everybody had it. They brought the ECT machine down the ward and gave it to everybody. And she wasn't afraid or worried because it was normal. 1970s, well, I think less than the 1950s, definitely. And it does go down year on year. But when we did it in 2003, we got the stats off the Department of Health, and 11,000 people had it in England that year, which is not a small number. That's 12 treatments. It's 11,000 courses.